we can do probably better. Those data from the Canadian, I think it's a study from Ontario looking at patient who had acute myocardial infarction with cardiac shock. 15% of those patients underwent temporary MCS. And if you look at the type of MCS, 15% were intra-aortic balloon pump and very few use of Impella and VA ECMO. And the survival at 1 year is 60%, 5 years 45%, and 10 years 32%. So you can use those numbers as to try to remember the prognosis of post-cardiotomy, post-infarction cardiogenic shock. I think was maybe the only thing to remember is that shock team is everything, and it's not in all the center that there is a standardized shock team. And so it's very important to keep that in mind. Usually shock team, that can be, you can have a little bit of variability, but usually there is a heart failure cardiologist that is involved and usually who leads the shock team. You also have an interventional cardiologist. You can usually cardiothoracic surgeon, an intensivist, if not a cardiologist is not an intensivist. Also, cardiac anesthetist may have a great role to play, and the critical care nurse, perfusionist, and respiratory therapist. Those patients are critically ill patients, and they require many resources to take care of them. And actually, it's interesting to see that the study looking at that, the role and the impact of the shock team on outcomes, this is probably the most important thing that demonstrated an improvement of survival. If you compare either within the center before or after the implementation of a cardiogenic shock, you can have an increase of survival as much as 25% or 30% survival. So it's extremely important to keep that in mind. And why? Because interestingly, when you have a shock team in place, the rate of overall use of MCS is lower than in center without a shock team, but the type of MCS is slightly different. And you can see here on this slide, the overall MCS 43% compared 35%. And the advanced MCS, so meaning ECMO or Impella, is higher. And also the rate of use of invasive monitoring, such as a pulmonary artery catheter, is higher when you have a shock team than without a shock team. And there is a slight impact on ICU mortality. So it's extremely important. The other aspect is also the system of care. Because we talked about the spoke and hub model. So the spoke hospital or usually the primary hospital, because the patient in cardiogenic shock can present everywhere, and with no shock team or less advanced care. And it's really important that those centers can speak quickly in a timely manner to a hub hospital with more resources and to define the trajectory, the proper trajectory of the patient, either direct in the cath lab or in the OR or in the ICU, and eventually to decide upfront, even before seeing the patient, what he's going to need, because again, time is end organ function. So if we look at the contemporary management of cardiogenic shock, basically, it's you can divide this with first step is early recognition, shock team activation, and those is purely clinically guided. Then you have to phenotype and stratify the cardiogenic shock. And it's important because first you're going to have the prognostication, and that will eventually determine what the patient will need. Then you have the therapeutic decision and to treat the underlying cause, of course, and then the continuous monitoring. And all of this process should be standardized as much as possible within the multidisciplinary shock team and with very clear protocols. I think it's very important. Why SKY classification is important? Because many studies demonstrated that there is a clear and very strong correlation between the stage of the SKY classification with when the patient is stage E, the mortality can be as high as 80% or 70% compared to stage C, which is around 30 to 40%. So in terms of phenotyping, what do we mean by phenotyping? It's usually the work of medical history. So what would be the cause of cardiac shock with the basic workup with EKG, labs, and echo, and then you can try to have a good idea of the underlying cause. Again, in this data from the Critical Care Cardiology Trial Network Registry, which is probably one of the largest registry of patients in shock, cardiac shock, ischemic or half of the patient, non-ischemic with acute heart failure decompensation is roughly 25%, and other causes the other quarter of those patients. So to phenotype and to stratify, you will need numbers, and it's really important to determine and to have numbers either by echo or PAC. Because you will need to calculate the cardiac index or to have a surrogate of the cardiac index. That could be also the VTI with echo or just a thermodilution with the PAC. You will need to have the numbers of filling pressures on the right side, on the left side, and then you can derive all the indices we talked about, the cardiac power, the PAPI. You also will need to have biological parameters, hand organ function, lactate, SVO2, and liver function, because it's really important for stratification and prognostication, because you can divide the non-congested, the cardiorenal shock, or the cardiometabolic shock. The cardiometabolic shock being the worst because you have an impairment of both liver, kidney, or even brain function. So it's extremely important. Those steps are critical, and that's why you need to have those elements in mind when you are taking care of a patient in shock. The first stage would be to try to treat the underlying cause, especially for coronary revascularization in the setting of myocardial infarction, and eventually to think early about circulatory support to maintain end organ function and systemic perfusion. Just a word in terms of the first line of inotrope for medication. The first line medication is recommended is norepinephrine, and for inotrope, there is still a controversy between dobutamine and milrinone. The DOREMI trial did not show any benefit of one to another. What is clear is that epinephrine is not recommended anymore as a first-line drug for patients in shock, because it's associated with a threefold mortality in large meta-analysis. Now, when the medical treatment is not enough, so now we're gonna dig a little bit more in MCS. So we have a large armamentarium of devices available. You can have devices for the right side only, for example, Impella RP, the tandem heart with a Protect Duo, for example. You have only left-sided support with the intra-aortic balloon pump, Impella, the Impella family, the tandem heart, and for biventricular support, you have the VA ECMO. And you can see on this table the characteristics, and we're gonna go a little bit deeper in that. So now the question is how we choose the device for the patient, if the patient needs one. Again, it's based on hemodynamics. You need to determine if the patient is mainly left-sided, right-sided, or biventricular failure. And actually, if you need the right atrial pressure, an estimation of the pulmonary cardiac, the wedge pressure, the CPO, and the PAPI. And according to those numbers, you're going to decide what device to support only the right or left side or both ventricle. This is an example of algorithm every center should have, or you should have in mind, For example, this could be a journey of patient in shock. So you receive a call for a patient with a cardiac shock. So you say, okay, it's a stage D. SCAI classification, it's acute heart failure decompensation. So you activate the shock team, you gather all the information need. Ideally, if possible, you do a TTE at least, and eventually right heart cath. Meanwhile, of course, you initiate the medical treatment with monitoring, oxygen, inotrope, vasopressor, volume management. And then you need to think, okay, is there a contraindication to MCS? If yes, no brainer. If no, then you're going to decide what type of device you're going to use based on the hemodynamics. For example, I put here when to say no, because I think it's really important, in a system where you have limited resources, it's very exhaustive management. And so it's and you want to avoid any futility in those patients. So you can age, it's a matter of debate, every center put some threshold. For us, for example, after 70 years old, it's pretty rare we say yes for a cardiac shock. You need to make sure that it's not septic shock or easy reversible other cause of shock. For patients who are extremely sick, with a lactate level above 14, pH below 7, a patient who has severe chronic disease, who have poor expectancy of life, less than 1 year. A patient, of course, whose wishes are do not resuscitate, of course, and with no vascular access. So for us, those are the red flag. We're going to dig a little bit into contraindication for Ipella, and for ECPR, we're going to talk in detail after the slides. So again, the use of intra-aortic balloon pump is not recommended anymore from those two trials back. It's been now 10 years ago. One of the first device I want to discuss is the tandem heart. It's not a common device. It's pretty rarely used because so the device, you may be aware of it, but usually, so you have to put a transseptal cannula. So this is the inflow inside the left atrium, and then the blood goes from the left atrium to the pump without any oxygenator, and you can insert another cannula in the arterial, in the femoral artery or axillary artery, whatever. So you have left shunt or left device. Though you can have a flow around 4 liters. The cannula size are between 12 to 19 French. And the tricky part is the transseptal approach. Usually it's cardiologists. Some cardiologists are familiar to it, but it's not very commonly used. But that does increase the cardiac power, the blood pressure, and it's a good LV unloading. The other probably more common, or the most commonly used MCS is VA ECMO, of course. So you all know what VA ECMO is. You can have very high flows up to 7 or even 7-8 liters per minute. So the cannula, you have plenty of cannula size, cannula types. Usually you can have a broad variety of insertion. Femoral is the most commonly used. You have a good RV unloading, but for LVs, we're going to talk about it. It's not necessarily good. You have an increase of cardiac power. You increase the afterload of the LV. But it's a good respiratory and circulatory support. There is no doubt. It can also be used in combination with the Impella, so it's called ECMELA or ECPELA. You also can use tandem heart cannula in the LA to decrease the to unload the LV or an intra-aortic balloon pump. And you can use also the other configuration with as a VA-V ECMO when you add inflow cannula, outflow cannula in the right side to increase the oxygenation. For example, we're going to talk about it. Just a word about the hemodynamics of patients with VA ECMO and the consequences of VA ECMO on LV. So you're going to have an increase after all. Those others modelization, it's mock curves. It's not derived from actually a real patient, but it's derived from computational work. And so you have an increase of afterload, an increase of end diastolic volume and pressure. You're going to have a decrease of stroke volume. That may increase mitral regurgitation and aortic regurgitation, increase myocardial oxygen consumption, and blood stagnation. That's why we have always in mind, do we need to unload or not the LV in patient with ECMO? And the way to unload the LV of patient on VA ECMO patient is, first, you can decrease the afterload by avoiding vasopressor or by to target mean arterial pressure around 60, not too high. And you can also use intra-aortic balloon pump or nitroprusside. And you can also try to increase the contractility with the inotrop. It's a two strategy you can use medically. If you look at the number of runs, those are derived from the ELSO data, which is the largest registry of VA of ECMO, international, many centers. So the number of runs drastically increased over the last 20 years of VA ECMO. And this is a survival, 30-day survival of all those patients. As you can see, since 10 years ago, it's around 40-50% survival, all comers with no improvement. And pretty much the same from other multi-institutional centers. I think it's important to keep in mind, I encourage you to read this very nice meta-analysis looking at the outcome of patients with VA ECMO according to the etiology of shock. And of course, the worst mortality is patient with out-of-hospital cardiac arrest. It's around 80% mortality. A little bit less for in-hospital cardiac arrest. Post-myocardial infarction and post-cardiectomy, roughly it's 50 to 60% mortality rate. Pulmonary embolism is around 50, and the best outcomes are for after a transplant or for patients with myocarditis. And also a good indication, but a rare indication is for some intoxication because it's a very reversible condition. Some consideration for VA ECMO, so it's always to try to implant very early the ECMO, especially for patients in cardiogenic shock. Peripheral cannulation is usually associated with less complication. Technical aspect, we're going to go over that, but it's extremely important. We sometimes need to consider an LV vent. Again, avoid futility. It's a very important principle. And always think about exit strategy after that. So for VA ECMO, many configuration again. So the most common one is femoral cannulation. Usually we try to put artery cannula in one side and the venous side on the other, usually the right side. Because it's more a straight line trajectory. You can also have a venous axillary or axillary femoral cannulation or carotid femoral or central cannulation. So it's a very versatile technology. The VA, so VV, of course, it's it's only for respiratory support, but you can also use a VA-V ECMO. So you have a venous drainage from both jugular and femoral, and then you can reinsert in the arterial line. Or you can also drain the vein, the femoral vein, and perfuse the jugular vein and the artery with oxygenated blood if you have an Harlequin syndrome, for example. So we're going to talk about some troubleshooting. So VA ECMO, one of the most challenge, it's a complication, especially patient with a small vascular access, for example, congenital patient or the worst, like Fontan, they have very small access. Pulmonary edema, lower limb ischemia, hyperperfusion syndrome, and Harlequin syndrome. So you should know those complications, and you should know how to recognize them and how to manage them. I think it's one consideration is to try to cannulate where you are. If you have patient who are at the emergent department, and there is only CPR. I mean, if it takes time to transport the patient, you should be able to cannulate either in ECPR or in ICU, because to transport a critically ill patient comes with a risk, especially between institutions. But it depends on the resources you have. If you are able to have a mobile unit or not. One just quick note, it's very important to know the material you're going to use for wires, for dilators, for cannula, because they all have their specificities, and it's really important. For example, if you do only percutaneous, you can have very soft guide, and then it's very easy to kink the guide. And if you kink the guide, during a CPR, you need to remove it, and so that can be really, really tricky. So that's why you need to know the material, all the material before, and look at the ECMO cart, look at what is in it, how to use it. It's extremely important. You have a lot of cannulas. Some of them are multi-perforated for the venous side. Some are just perforated at the tip. And it's also, so it depends what you want to achieve. Usually we try to put the venous cannula inside the superior vena cava and the inferior vena cava to have a good venous drainage. Also to have a good idea of the size of the vessel, then to decide the size of the cannula. Usually in the more emergent situation, the smaller cannula you want to use, especially for the arterial side. Usually you can have a good perfusion with even a 15 French side, and you decrease the risk of complication. But it's important to know the cannula. For example, some cannula have a non X-ray. You cannot see the tip of the cannula on the X-ray, so it's important to know that. Otherwise, you can think it's not well placed. So it's important. And again, complication after on patient on VECMO are extremely important. If you look at this huge meta-analysis, the rate of, for example, major bleeding is as high as 40%. Leg ischemia is 15%. Stroke is 6%. Infection is 30%. Bleeding is 40%. So, and this is why I think technical aspects are very important. Again, if you want to do percutaneous, use echo guidance. I think it's now every cardiac surgeon should how to puncture a vessel with echo. Of course you're gonna know you have to know the anatomy. Again, it's good to try to separate the sites of cannulation. So the right side, usually we try to put the venous, the left side, the arterial. The idea behind that is to try to reduce the ischemia on the leg. If you decrease the blood return, plus you decrease the the leg perfusion, you may increase edema and you have a compartmental syndrome or whatever. Also, reperfusion cannula is a no-brainer. 100% of VA ECMO should have a peripheral VA ECMO should have a reperfusion cannula. It's a no-brainer. If you have difficult access, you may use a graft, but you're going to need a cut down to do that. And you have to keep in mind, if you use a graft to cannulate the femoral artery, for example, you may have an hyperperfusion of the lower leg. And usually it manifests with a huge edema and a hot leg, and you can have a compartmental syndrome in this setting. So if you document that, you usually what we do, we put a small snare on the distal artery just to decrease the flow on the distal on the leg, or you can just put the tip of the cannula inside the femoral artery through the graft. It's the other way. So you should be aware of some pitfalls for cannulation. For example, for venous cannulation, that's why you really need, it's optimal if you use a transesophageal echo guidance to make sure you can see the guide properly. Because if you have, for example, if you have a PFO, you can just put the cannula in the LA inside of the right atrium. You can also be in the subhepatic vein. You can have a Stachy valve that you can block the cannula. You can have a iliac perforation if you do not see the wire properly in the IVC. And for arterial cannulation, you can easily have bleeding, dissection, and especially in patients with previous vascular surgery, you should be very, very cautious. And again, TE guidance is extremely important. That's why you need to work with anesthetic or cardiologist who are very familiar with this to control that. And the other example of cannulation, you can cannulate the iliac artery, and when you decannulate, that could be really tricky. If you cannulate above the inguinal ligament, you can have a perforation of the vein. You can have, this is an example of in France, cannula inside that perforated the iliac vein in the retroperitoneum. So there are examples you may see. Limb ischemia, again, it's a no-brainer, and you should monitor the leg, the perfusion of the leg. We use a BIS to make sure that there is no asymmetry or the leg is properly perfused. If you cannot put a reperfusion cannula, it's good to have this bailout in mind. You can cannulate the posterior tibial artery. It's not necessarily easy, but you can save a leg by doing that. And it's well documented that you can decrease the complication. It's not always, but fluoroscopy is a good tool to use. Another aspect of the ECMO is when to unload or not to unload. So again, we said that VA ECMO may increase LV afterwards, after load, and so it's now from the literature, the patient who are more at risk to develop lung edema or patient with a profound biventricular failure, for example, severe myocarditis or myocardial infarction, primary graft dysfunction, or ECPR. A patient who has a CKD because the volume management will be more difficult to do. And those are the manifestations you can see. It's extreme, but you have foam in the ET tube. You have white lung, smoke in the LV, and eventually thrombi. So those are obvious sign of pulmonary edema and LV distension or congestion. So how often does it occur? So the first thing, if you have that, the survival is extremely impacted for sure, and you can decrease survival by 2 if you look at patients with or without pulmonary edema. And of course, associated factor are also the time on VA ECMO, the volume status, and the ECMO flow. And what is tricky is or difficult is because there is no clear consensus or definition of what is LV dysfunction or distension on patient on VA ECMO. The only thing you can assess is the consequences of that. But for example, if you have a permanent closure, or if you see that there is a clear increase of LV and diastolic diameter throughout the ECMO run, so it's a good sign. If you have no pulsatility on the arterial line, and if you have an increase of the wedge, if you have a Swan Ganz, those are indirect good sign of pulmonary edema or LV distension. And so in terms of strategy, you have many strategies that are described. You can do an LV unloading directly by if you put a pigtail through the airlick valve in the LV. I do not recommend that. We tried; it doesn't work very well. The intra-aortic balloon pump is an indirect LV unloading, and it's interesting because it works pretty well. Some centers use intra-aortic balloon pump in every VA ECMO. You can also use active unloading with a transseptal cannula or an cannula at the LV apex, or an atrial septostomy as well. It's very efficient, but you need to do a transseptal approach. And now there are pretty good data that intra-aortic balloon pump for LV unloading is efficient, especially in the prevention. It's more difficult to use intra-aortic balloon pump when you have pulmonary edema. You need something more efficient, but it's very efficient to prevent it. And the most common way now is to use Impella for LV unloading, and some studies suggested a better survival if you use Impella, ECMELA versus ECMO only, VA ECMO only, because you may decrease oxygen consumption. But I think the level of evidence is not here to use Impella in every VA ECMO patient. We are far from that. Just a word about risk of embolization. For example, if you insert bubbles in the right side, which by not using bubble filters in the lines, for example, you may have embolization of bubbles on the left side or on the arterial side. So it's really important to use bubble filters in VA ECMO patient, and it's well documented with transcranial Doppler. So the Harlequin syndrome, for those who do not know what it is basically when you have the heart starts to recover and pump again some blood, but you have a lung failure, and so the deoxygenated blood that comes from the lungs in the LA goes in the ascending aorta and in the innominate trunk. This is the reason why for VA ECMO patient you need to monitor blood gas on the right arm, just to make sure that there is no Harlequin syndrome or good oxygenation, and on the right side. And the treatment again is to switch to VA ECMO, to a setup of VA ECMO, and eventually to downgrade to VV ECMO if necessary. I will go very quickly because for the sake of time, and I have a lot of stuff to do to talk about. But percutaneous decannulation starts to be more often used, especially with the MANTA. So with good technical success, but you need to how to use it, and you need to measure before the cannulation the depth of the arteries. That's why it's kind of tricky to use, but you can use it, or you can use a perclose. Now, in terms of data, I think one of the most important recent study is the ECLS cardiogenic shock. ECLS shock published 2 years ago now, And actually, it's a randomized trial that compared the ECLS plus PCI and medical treatment to conventional management for patients with a STEMI or NSTEMI and cardiogenic shock. You can see here the inclusion criteria. So if you have a patient in cardiogenic shock defined as we discussed, with the planned early revascularization, those patients were randomized. So 400 patients were randomized. And the primary endpoint was all-cause 30 days mortality. And the secondary endpoint were discharge to ICU, discharge to home, neurological status, complication, and a follow-up. Exclusion criteria, so patient with a CPR above 45 minutes or mechanical complication of acute myocardial infarction or severe PAD, age above 80 years were excluded from that study. If you look at the patient characteristics, so the mean age was 60 years. Most of the patient had a STEMI, and 77% had CPR before randomization. So those are very sick patients. LVEF 30%, lactate level 6.8. So most of the patients were in stage C, D, and E, mainly stage C, but those are very sick patients. So 92% had a ACLS on the ACLS group, and in the control there was a crossover of 12% with 12% of patients who had ACLS on the control group, and VA ECMO was mainly was inserted after PCI in 50% of the cases in the ACLS group, and either before or during PCI in 25%. Only 6% of patients had active LV venting. It was one of the limitations described, and almost all patients had a limb reperfusion, as we discussed. And now, in terms of primary outcome, there was no difference in all-cause death at 30 days, with 47% versus 49% of mortality at 30 days in both groups. Higher rate of complication in the ECMO group with a 23% of bleeding and vascular complication in 11%. So basically, it was a negative trial with no clear subgroup of patients that might benefit of VA ECMO in that setting. However, it's the strongest evidence of use of for the use of ESLS in acute myocardial infarction and cardiogenic shock. The crossover and the fact that most of the patients had CPR before randomization are some limitation. If we look at now, this table is a little bit busy, but basically it does summarize the trials, the randomized trials of comparing VA ECMO to conventional management, and actually, and what you can see, there is no clear, there is no trial showing clear benefit of VA ECMO. And as the same as a recent meta-analysis here. So overall, there is a lack of proof of the benefit of VA ECMO in the context of cardiogenic shock in those randomized trials. Why is the reason? It's many reasons can be discussed. One thing is important is the timing of VA ECMO insertion, for sure. The earliest probably the better. That's why again, time is end organ function, and if you just focus on myocardial revascularization, for example, but the patient is dying on the table, the outcome won't be great. And some evidence demonstrate that, either in post-transplant or in a cardiogenic shock, if you want to use a device or VA ECMO support, do it early. ECPR, it's a little bit, it's a specific condition, and what is extremely important in ECPR, it's to have good criteria, and to stick to those criteria. For example, the low flow, the time of low flow is extremely important, and after 5 minutes of no flow, there is almost no benefit to ECPR. It is ECO2 during the quality of the ECPR is extremely important. The duration of flow extremely important as well. So the criteria are extremely important, and age as well. That's why for us, after 60-year-old, we do not consider ECPR. If we are not able to reperfuse or to insert the ECMO within 60 minutes after the onset of the cardiac arrest, we won't go for ECPR because unfortunately it's futile. So it's very important to have good criteria. And another trial, important trial for VA ECMO is the Inception trial, published also 2 years ago, and you should be aware of this trial for your Royal College. And actually, it's a randomized controlled trial with the objective was to assess ECMO plus conventional CPR to conventional CPR, and to assess the survival with favorable neurologic outcome. So inclusion criteria was less than 70-year-old, initial shockable rhythm with VT, VF, and a refractory cardiac arrest defined with cardiac arrest more than 15 minutes without return of spontaneous circulation. Of course, the exclusion criteria were common sense based on the comorbidities of the patient. And again, if you cannot cannulate the patient within 60 minutes. And if you look at, so it's very challenging to put this type of trial, and they randomized 70 patients on the ECPR group, and they compared 64 patients on the conventional group. It's interesting to see that only 70% of the ECPR had actually VA ECMO. And if you look at the outcome, there were no difference between the two strategies in terms of survival with good neurological outcome. So again, a negative trial. However, we use VA ECMO quite often, and we use it as a bridge. We can use it either bridge to recovery, bridge to transplant, or bridge to bridge, or bridge to decision. It's clearly the only thing that can provide its time. And for example, if you take this example of 45-year-old female on VA ECMO, post-cardiac arrest, cardiogenic shock, LV apical thrombus, so you cannot put in Impella, undergoing non-revascularizable coronary artery disease. So what are we going to do? And you have several pathways again. Eventually she will recover, but it's not very likely. You can either decide to direct bridge to transplant, but you have to take in mind the time of the support. You can use a bridge-to-bridge strategy with another type of MCS. You can just say, okay, it's going to be palliative care, or eventually to be able to remove the ECMO and then transplant her afterwards, or use a durable VAD as a destination or bridge to candidacy. And just start to cut the story. I think the important consideration is first decide if the patient could be a transplant candidate. And the first question that comes is neurological integrity and no heart transplant contraindication. So if it's the case, is there a prohibitive risk of death after transplant? And those are the criteria associated with a very bad prognosis after transplant on VA ECMO. And if no, again, you need to take in mind the expected prolonged wait time. For example, in Canada, it's difficult to have donor in within a couple of days, and so if it's the case, you need to think if you think that you're gonna stay on ECMO for 7 days or more, you need to consider an exit strategy as a Centrimag or a VAD. Otherwise, if you think you can have an organ fast, you can just go for transplant. Now, so we're gonna go a little bit over the. We're gonna talk about the Impella. So Impella family, as you know, there are several iterations of the Impella. For us, I think the Impella 5.5 is the most commonly used device as surgeons. What's interesting is so Impella, you may all know what it is. It's a microaxial pump flow. You insert it through a peripheral artery, and the tip of the cannula is in the LV, and the blood goes from the LV to the aorta through a rotational pump. You have the Impella 2.5, the Impella CP. The Impella 5.0 is not available anymore, and now it's the Impella 5.5 for the left side. And they have different characteristics. The Impella 5.5, it's surgically implanted. Usually it's 19 French cannula and a 19 French motor size and a 21 French cannula. And you can that can provide around 6 liter per minute. The CP is probably the most commonly used by cardiologists. The CP is 14 French. Usually you can use it through the femoral artery most of the time, and that can provide around 3 liter per minute. So the Impella, the indication usually can be cardiogenic shock with the left side cardiogenic shock, for post-cardiotomy shock as well, either for recovery, for bridge or bridge to decision. There are some other less common indication for some center use it for VSD, even though it's counterintuitive, but some paper describe good results for high risk procedures for PCI. Some surgeons do use it for patients with a high risk cardiac surgery with a very low EF as a preemptive strategy after the surgery. We can use it as de-escalating from VA ECMO. I think it's really interesting strategy, and to unload the VA ECMO or optimization before LVAD implant. We can sometimes try to stratify the right ventricle or the kidney function with that. So the contraindication, absolute contraindication, is moderate to severe AI, aortic dissection. If you have a free mobile LV thrombus, stent is the ascending aorta, mechanical aortic valve, obviously. If you have a significant right ventricular failure or concomitant respiratory failure, those are absolute contraindication for Impella. You should be aware that a small vessel diameter could be very tricky to insert if you have a femoral or axillary artery less than 7 millimeter, severe calcification as well, or aortic valve stenosis, of course. So again, this is the anatomy. So it comes with a kit, with the insertion kit. I don't know if you've seen that before, but you have, so the Impella, you have a 9 French catheter. Then you have the motor, 19 French, the semi-rigid cannula, 21 French, and it's not very rigid actually. That's why you don't have, when you try to insert and you have tortuosity or calcification, you can really not push very hard, or you're gonna have a kink. And this is the inflow area, usually that is in the LV, and you have and this is go through the aortic valve. And on the echo, you must have 5 centimeters between the aortic valve and the tip of the cannula. So in theory, you have 5 to 6 liter of flow. You have a good LV unloading for sure with the decreased myocardial oxygen consumption. So it's a preload dependence. It's really important to have that in mind. This is why in RV failure it doesn't work. And it's also afterload sensitive. So if you have very high blood pressure, the flow going to be decreased, and you don't want a high pressure in a heart failure patient. The other thing is the console. You have a pressure sensor close to the motor, and so this is the only thing that is measured with the on top of the RPM. And you have a pressure sensor here, and you have a console that can calculate real-time hemodynamics. So the surgical aspects, you can use a standard axillary approach, either in the deltopectoral groove or in clavicular approach. It's very important again to look at the CT scan before. If you can avoid to cut the pectoralis minor to decrease the bleeding, you need to control very well the distal and the proximal part to do 10 millimeter of arteriotomy. You need to bevel the 10 millimeter graft around 50 to 60 degrees. And to keep the graft around 20 centimeters. Then you enter the cannula in the graft, and you put those lockers around it to get the hemostasis, and you insert the sheath inside the cannula. Inside the cannula. I have a video, but I think for sake of time, I will pass that. I just give you the principle. So you can use it in either in axillary, which is the most common, on the right, left side, or left side. Actually, the left side is easier on the curve. You can use it axillary, or you can also use it direct aortic, for example, for post-cardiotomy shock. But if you do that, you need to keep in mind that you need to have a good distance between the flow on the graft flow on the ascending aorta and the aortic valve, and you need to use this cool toolkit to make sure you're going to have a good distance between the graft and the aortic valve. Usually what it is required, you give IV heparin to get an ACT above 250. If you are on bypass, for example, you can reverse fully the heparin. And afterwards, you can use IV heparin with an ACT around 160 to 180. TE guidance is extremely important. Fluoroscopy guidance is also recommended, but you can use it. You cannot. You can insert a 5.5 without TE guidance, fluoroscopy guidance in the OR. It's also important to know what to look at on the console. For example, you have information about the placement. So on the red curve, this is pressure, the aortic pressure measured by the captor. On the white curve is a current, is a derived pressure of the LV. And here on the green curve, it's a motor current of the impella. And to be able to make sure that the placement is good, you have to have an oscillation on the motor current and a flat line on the aortic pressure. And on the TE, you have to make sure that the angle is within the aortic valve, and to have 5 centimeters of inside the LV, away from the mitral valve apparatus. It's really important. For example, of an incorrect placement, you have a LV pressure on the red curve, which is not good. That means that the impella is too deep, and you can also have a suction alarm when the pressure on the LV is too low. and with a very large oscillation on the current curve. And usually you have a flow below what is expected for the speed of rotation. So it's some other consideration is very important to secure and check the connection, because it's very easy to kink in the ICU. So that's why you need to fix it properly. It's very important to monitor daily with echo the placement of the pump. The X-ray is not great, so echo is the best way to do it, and to look at the hemodynamics as well. Of course, the patient can deambulate easily with an axillary approach, and to do some daily labs, especially to look at hemolysis and kidney function. The most frequent complications we see is improper placement or dislodgement, hemolysis, acute kidney injury, stroke, or vascular problem complication like bleeding, ischemia. It's pretty rare. So what are the evidence behind the Impella? Actually, it's pretty scarce, especially before the danger shock trial. So the main trial was the IMPRESS trial. You may know it, but basically it was a randomized prospective open label multicenter trial between 2012 and 2015. In patients with acute myocardial infarction and STEMI cardiogenic shock. They get randomized, so they randomized 48 patients, either with intra-aortic balloon pump and medical treatment, or Impella CP and medical treatment. The patients were pretty standard for cardiogenic shock with a lactate level above 7. And the primary endpoint, which was 30-day mortality, was similar between the two groups, 46% and 50%. So there is no benefit compared to intra-aortic balloon pump of the Impella. So it was a negative trial. What is interesting, they just published the 5-year follow-up, and actually in the mortality in Impella group was lower than in the intra-aortic balloon pump, but it's not clear if it's just a cardiac-related outcome. And the real game changer, at least for cardiologists, was the danger shock trial published last year. So the objective was to assess the efficacy of the Impella CP compared to conventional treatment for patients with STEMI and cardiogenic shock. It was initially started in Denmark, then they expand to UK and Germany. And in 10 years, they tried to recruit 360 patients in 14 centers. The inclusion criteria was 18-year-old with STEMI and cardiogenic shock, and LVEF less than 45%. Patients on comatose after out-hospital cardiac arrest were excluded, or patients with ventricular failure were excluded. Primary endpoint was death from any cause at 180 days. And they look also at several secondary endpoints, safety endpoints, and adverse events. So I put here the patient characteristics, some of them 67 year old, mainly male, as usual. Left ventricular ejection fraction 25. Half of the patients were in stage C of the SCAI classification. The other were in D and C and E. Most of the patients had a 2 or 3 vessel disease, and the time from onset of the STEMI and the randomization was 4 hours, which is pretty fast, actually. And Impella was placed before PCI in 84 patients who were randomized before PCI. So I think it's an important message. Regarding the need for escalation to additional MCS, it was pretty similar between the two groups. And if you look at the outcomes, those are the primary outcome. You have this trial showed survival benefit for patients with Impella, with a 45% of survival compared to 45% of mortality compared to 58% of mortality. So it's interesting, but still it's still really high, and it's still close to the number we saw from previous trial. The NNT was 8. And if we look at the secondary composite cardiac endpoint, it was also better with the Impella. However, it's important to keep in mind that in terms of complication, the rate of complication were higher in the Impella group, and the number to harm was 6th. So if we do the real benefit, it's less appealing. However, in terms of composite cardiac endpoint and days alive out of hospital, it was in favor of the microaxial pump group. But all the adverse events were higher in the Impella group, especially major bleeding or limb ischemia, and especially the renal replacement therapy, which are twice with the Impella than conventional device. So it's the mortality remains very high. It's almost the same than in the ECLS shock trial. And there are some limitations with the low and difficult recruitment. So those patients are very, very selected, and it's a narrow population of patients with cardiologic shock. However, I do think that's going to change the practice for cardiologists. Here I just put in perspective the two trials, so I won't go over it because I already presented the two trials. But you're gonna have the slides, and I think for you it's a good exercise to put those two trials in perspective, especially for maybe for the Royal College, I don't know, but to see what are the differences and what are the endpoints. But again, if you look at the mortality rate, it's pretty similar between the two trials. So it's I mean it's not clear if there is a real benefit of the Impella in this setting. I think we have a couple of minutes less, so I have some slides about the isolated right ventricular failure. I think it's really important to have a little bit of physiology in mind, and the determinant of AV failure are the preload, the contractility, and the afterload. So you need to act if you have a patient with right ventricular failure. You need to add on those three elements. So for the preload, you need to make sure that the patient is not volume overloaded, and to eventually use diuretics or the opposite to increase the fluid. And for contractility, it's basically make sure that there is no arrhythmias, that you can you use inotropes to make sure to treat the underlying cause. And for afterload, you need to decrease PVR as much as you can with a good oxygenation, with the normalized pH, with eventually pulmonary vasodilator. And the parameters you want to monitor is CVP, the MAP, and the cardiac output. And those are the things you want to manage and to act on for patients with RV failure. In terms of support, we have a couple of options. Impella RP is seldomly used. We have no experience with that, and there is very few publication. There is more data, a little bit more with the Protect Duo, which is an appealing strategy with a double luminum cannula with an inflow of the pump in the left atrium and the outflow of the pump in the PA with only one cannula that is inserted percutaneously. The tandem heart as well, you can use it centrally. You can use a Centrimag or VA ECMO as a support. For us, the first line support in the acute setting is VA ECMO for right ventricular failure. And finally, I mean, I just put here some very general comments, but again, I think the keys to improve outcomes in patient in shock and in temporary MCS is shock team, because as we saw, there is no clear strategy that may increase survival, either via ECMO, a little bit maybe Impella, but clearly it's a shock team is extremely important. Patient selection and avoidability, device selection mainly based on hemodynamics and patient severity stratification. Again, techniques matters, even if it's a simple procedure. It's very important to know the material you're going to use and to be familiar with. And to have a team dedicated multidisciplinary team. And the system of care also is extremely important. I put here a list of high yield studies and guidelines you should look at for this topic. And I leave this to you now, right on time.
Amazing. Thank you so much, Dr. Noly, for your time. You clearly put in a lot of effort into this presentation, it shows, so thank you so much. We only have a few minutes till we start our next session, so maybe what I will do is, if there are any really important kind of burning questions, maybe we'll answer a couple. And then after that, Dr. Noly, would you be open to maybe just leaving your email in the chat and people can email you after?
Yeah, absolutely.
Perfect. So maybe let's do that. If anybody, I don't see anything in the chat currently, but if someone, maybe it would just be faster to, raise your hand. Perfect. Yeah, Kenza?
Thank you so much, Dr. Noly. This was so helpful. My question is regarding the placement of an Impella in the context of a VSD, or ventricular septal rupture. Do you go as deep in the LV? Or how do you manage that?
I have no experience in this setting, to be honest. I just spoke with a couple of friends in France, and they published their experience, I think, in JCCVS or in one of the paper, and they presented in conference. But they use a regular placement, and interestingly, there is no right to left shunt in that setting, because we can say, okay, you're going to have a deoxygenation if you suck the blood from the RV to the aura, basically, but they do not see that. So basically, they just reduce the LV pressure and reduce the shunt, but the shunt is still there, and so there is no desaturation. But the placement seems to be the same. My concern is about embolization, because we know how friable the muscle could be in VSD, but they did not report any stroke or not much that in this setting. But we haven't tried it yet. For us, it's for VSD. You're gonna talk it about later. But there are, I don't know, Stephen, what is your approach in I don't remember I've seen it in Alberta at the MAS, but it depends on the clinical state of the patient first. And if we decide if we go for MCS or for surgery, it depends. It's case by case.
And sorry, Pierre, are you referring to the use of MCS in the presence of a post-MI VSD? Is that the question?
That's correct.
It's a little variable. I think still we would, normally try and go straight to the OR and fix it, acknowledging there's a high likelihood we'll come out on MCS. Increasingly, and I can't say there's any specific parameters that make us decide this, but occasionally patients will come in and we will initially put them on MCS to stabilize them. Usually it's the ones that are in severe end organ dysfunction. Taking someone to the OR that's already got acute liver failure, maybe questionable brain function. They may not do so well, and those are the ones that we will maybe sometimes try and put on MCS for a few days, temporize them a little bit, let their end organ function improve a little bit. Sometimes they declare themselves as not a candidate for anything, but it's kind of case by case.
Yeah. For us, ECMO, for example, is a triage tool more than anything else.
Very correct. We don't have a lot of experience with Impella here yet, at least not 5.0, so I can't comment on the role of Impella in a post-MI VSD patient. But while I have the microphone, and I'll put on my program director hat here, thanks again, Pierre, for doing this talk. It's very important. There's, I think, 26 cardiac surgery centers in Canada right now. And all these centers should, no matter which center you end up in your career, whether you're working at a center that's a quaternary, transplant, HeartMate 3 center, or you're working in a slightly more community-based center, everybody has to know how to assess patients for ECMO, be able to put patients on ECMO, manage those ECMOs. You clearly highlighted the hub and spoke model, and then sometimes you will be transferring those out. And we can think of many examples across the country where there is that hub and spoke model. So everything we saw here today is incredibly important for.
I just had a referral here for our program for our osteoarthritis.
Okay. Is it? Very important for everybody to know how to do this and manage these patients. So excellent talk, very relevant for anybody going out into practice in the current era, for all the trainees.
Thank you, Stephen. But again, I cannot put enough energy saying that even if it's stupid procedure, technical aspects are very, very important. If you puncture multiple times a femoral artery, you're gonna have a bleeding. So it's very important to do it properly, even if it's a simple procedure. That's why we have some intensivists. They are trying to cannulate. But we see catastrophe if it's people who are not doing it properly.
And if you don't, it's going to haunt you too, right? If you don't put in that LV vent and you're in the OR post-cardiotomy shock and you're tired and you've been there all day with the case and you're like, well, put them on ECMO, probably should do an LV vent. Oh, I'm too tired. Guess what? You're going to be getting called back in a couple hours for that vent or anything else. So if you just do it right the first time, put in that little extra effort, usually when you're super tired, you just got to make that little bit of extra effort and you'll have a very stable ECMO. It was interesting, that one graph you showed with the varying outcomes over the last 20, 30 years, and then how it's really stabilized over the last 10 years. I think we've all learned from our mistakes. I think we've all gotten very good at it, but you're right. We've hit a plateau, but we're also not making a lot of the mistakes that we used to. I don't know if we'll be able to get the outcomes any better in the future, but hopefully we don't have those NAD years with, I think one year there had like 100% mortality with ECMO on that one slide you showed. So again, just do it right.
Yeah.
Perfect.
It's hard. It's sometimes hard when you're really tired and struggling and you're worn out, but there's no choice. So good.
Awesome. Well, thank you guys so much again, and thank you so much again, Dr. Noly, for your time. Dr. Moran, I think I saw your hand was up there.
I just wanted to catch Pierre-Emmanuel before he leaves. Pierre, did any of your colleagues talk about, I know the shunting with Impella is something we worry about. Is there any concern as well for embolization of like necrotic material or?
So from their part, no, but for us, yes. That's why we haven't used it yet. But yeah, no, it's
interesting. Thank you.
Perfect. So I think with that, we're now just past, I guess it's 2:30 EST. So what we'll do is maybe we'll give everybody a 5-minute break, and then Dr. Moran will give his presentation. So thanks again, Dr. Noly. Appreciate it.
Thank you. Good luck for those who have their exam, and good work for the others. Bye-bye.
Alrighty, guys. Just for the sake of time, I'll introduce Dr. Muller-Moran now so that hopefully we can kind of get his presentation going for 2:40 EST. For those of you that weren't here for the initial part, my name's Asher. I'm a second-year resident in cardiac surgery, obviously, at University of Manitoba. And myself, Therese, and Yuan have been running the National Academic Half Days this past year. So without further ado, I will introduce Dr. Muller-Moran. So Dr. Muller-Moran is a cardiac surgeon here at St. Boniface Hospital in Winnipeg, Manitoba. He completed his medical training at University of Manitoba, received his Master's of Science in Experimental Surgery from McGill. He did his residency training in cardiac surgery here at University of Manitoba, and then completed an advanced adult cardiac surgery fellowship at Northwestern Memorial Hospital in Chicago. His research interests include surgical education, simulation, curriculum development, surgical outcomes research, as well as intensive care outcomes research. Today, Dr. Muller-Moran is going to be discussing with us mechanical complications after acute MI. And Dr. Muller-Moran, if you are ready, you can share your slides whenever. We're looking forward to it.
Awesome. Thank you, Asher. I'll go ahead and share. Okay, are you seeing this as full screen?
Yeah, looks great.
All right, fantastic. So yeah, let's jump right in. Asher did most of the introductions already, but you know, I was looking at the attendees. I think I know a fair number of people in the audience. So I've been fortunate enough to work in sort of several centers around the country, and always happy to see you guys and to share knowledge with each other. I think that's one of the strengths of our cardiac surgery community in Canada, is that we're so close knit. It makes it really easy to exchange ideas and to really, you know, provide great care for our patients. And I do think we provide fantastic care. I think our outcomes speak for themselves. Okay, so for today's talk, I thought, you know, keep it relatively straightforward. So I'll talk a little bit about what exactly do we mean when we say mechanical complications. We'll talk more specifically about the individual lesions, specifically focusing on medical, surgical, and post-operative or ICU considerations. Where relevant, I'll talk about percutaneous options. And then finally, speak a little bit about the role of MCS, which I know Pierre-Emmanuel has done a fantastic job on, as well as the role for revascularization. And I'll sort of sprinkle in as tidbits where you know, I think that there might be particularly relevant Royal College material, because I know that's always in the back of everyone's mind. So so we talk about mechanical complications. You know, generally in my mind, I think of these three entities. So firstly, ventricular free wall rupture, which is of course where you know, it's as it sounds, there's a necrosis within the ventricular myocardium from ischemia, which eventually causes a rupture of the cardiac chamber and tamponade with hemodynamic instability. You know, historically, these have probably been underdiagnosed. I think this is true for all mechanical complications, but for a rupture especially, underdiagnosed because people tend to die from this. Like they don't make it to the hospital in time. They become very acutely unwell. They may pass away, and certainly historically in studies done on cadavers, when patients are sort of with a diagnosis of sudden death, a disproportionate number of them have, you know, evidence of complications like a free wall rupture. So they're probably underdiagnosed in the you know, contemporary literature. VSD, so similar pathology, but instead of the myocardium being necrosed and rupturing externally, you have rupture of the intraventricular septum, and that's yeah, that's perhaps a little bit less unstable, although these patients can still become quite unwell, than a frank free wall rupture. There's typically a large component of RV failure. There's left to right shunting, but since they don't have tamponade, they kind of can hold their own a little bit more. And then finally, we talk about acute MR, which in the context of an MI, acute MR can mean several things. Can be firstly just papillary muscle dysfunction from ischemia and from tethering of the mitral valve leaflets. This can refer to ventricular dilation resulting in like functional MR, or more germane to this talk, can be actually rupture of the papillary muscle itself. So again, similar pathophysiology as far as ischemia and necrosis of the myocardium. Once the papillary muscle ruptures, by definition, you end up with severe MR. And I'll talk a little bit more about the sort of etiology, but as far as vascular supply of the papillary muscles, typically this is associated with RV infarction as well. So, you kind of develop a triple hit phenomenon of not just the infarct, but then severe acute pulmonary edema, followed by RV failure. I have a little bit, these are sort of outdated photos, but this clearly shows ventricular free wall rupture. This is showing frank rupture of the papillary muscle. And then this is a very thinned heart, but showing signs of a post-infarction VSD. Now, one of the things that's kind of interesting is a lot of people will tell you nowadays that we don't see these conditions very often. And because of advances in care, patients, they don't present how they might have presented, 30 or 40 years ago. And, basically these conditions aren't all that common. One of the things that we sort of talk about in Manitoba is we have a fairly unique geography because we're the only center in the entire province. We serve, almost 1 million people. And granted, a fair number of those are located within the Winnipeg area, but we can have people coming from very remote locations, sometimes from fly-in only communities. And so, we feel that we actually do encounter these with a fair amount of regularity, simply because the nature of our geography means that patients can be, presenting to us with prolonged periods of ischemia. Certainly in my residency, I was involved in a number of these, even as a staff, and I've only been in practice for 6 months or so now. I had a free wall rupture that I had to deal with one night. So they happen, and I'm sure Therese and Asher have also, experienced these early on in their training. So it's still something that we have to deal with in Manitoba, even though that may not be necessarily the case for the community at large. I want to take just a moment to touch on chronic versus acute mechanical complications. So some of you in your studies, you may have come across ventricular aneurysms or even pseudoaneurysms, and these are often lumped as well with mechanical complications. I didn't really want to go into these for the purposes of the talk because, in my opinion, they're more chronic manifestations of ischemia and more associated with heart failure. And their management is a little bit different because these patients aren't necessarily as acutely unwell as the group that I'm going to talk about. I still think you need to know what these are. So you need to know what makes an aneurysm different from a pseudoaneurysm. You need to know that there was a stitch trial that actually included an arm of patients with ventricular aneurysms and compared the outcomes with surgical ventricular restoration. And you should know as well that the trial didn't demonstrate a difference in management arms. But again, just putting it out there, you should be aware of these, but I'm not going to be going in depth about them in my talk. So historically, mechanical complications occurred with an incidence of about 1 to 2% of acute myocardial infarctions, which on the surface might seem low, like only 1 to 2%. That's not terribly high, but when you consider that bicuspid valves occur at about the same rate, and how often we see those in our practices, you can appreciate perhaps that older generations of physicians did encounter these with greater regularity. Currently, as I mentioned, these are not generally encountered as often. Figures suggest that it happens at about 1/10 of the rate that it did previously, so about 0.2% in the current era. And this reduction is largely attributed to benefits of early reperfusion with either thrombolytics or even PCI. This is sort of a generalization, so always maintain a high index of suspicion. But there's an interesting profile of patient here that classically, or at least according to textbooks, tends to develop these types of complications, and that's patients who are actually generally probably healthier than what we're used to seeing in the cardiac surgery population. So we see a lot of people with chronic CAD. We see a lot of people with longstanding angina who, even if they have CTOs, have sort of progressed over time and developed collateral networks. Well, when it comes to mechanical complications, generally these are people who don't have well-developed collateral networks, who nonetheless suffer an acute occlusion of a culprit artery. They don't have the history of longstanding ischemia to allow their myocardium to benefit from ischemic preconditioning. And so when an infarct hits, it can injure a large component of the myocardium without any collaterals or any sort of backup mechanisms in place to allow that heart to continue functioning. And I always thought it was interesting that classically non-smokers are at higher risk here. So I think this might be one of the only conditions where smoking is actually potentially protective, because of course smokers will tend to have more diffuse CAD and probably progress more gradually, or present more gradually than someone with a non-smoker with a sudden occlusion of a single artery. This is just demonstrating a timeline of incidence of mechanical complications with time, and then that's on the left axis that you can see there, and then mortality on the right. So mortality in the bars and incidence in the dots and lines. So historically, if you think back to the 80s, our management of MIs was very kind of rudimentary. So people would come in with a STEMI or what have you and be put on bed rest, and because we didn't want them to exert themselves, we wanted to protect their heart. And they would sit there for angina. Maybe they get a little bit of medical therapy, but certainly nothing that we're doing nowadays, almost 40 years later. And so unsurprisingly, if patients were sick enough to develop a complication, there was a greater than 50% mortality rate. And this is the era where these complications occurred more frequently. Later developments with fibrinolysis and PCI definitely had some improvements as far as reducing the incidence, but it really wasn't until both treatment modalities got sort of combined in concerted care systems that we really saw the most drastic reduction in the incidence of mechanical complications. And like I said, now it's about 0.2% or a tenth of what it has been historically. One thing I want to draw attention to is that mortality has remained relatively stagnant or constant for the past 30 years. So despite improvements in care processes that have limited the occurrence of these complications, people still become quite sick with them, and mortality is still in the neighborhood of 40%, despite all the improvements in care. I thought it'd be helpful to talk a little bit about, on a biochemical basis, the evolution of MIs. Certainly, this is the type of question that the Royal College likes to ask. So, what is happening on a microscopic level when someone is presenting with angina or with acute ischemia? And as far as we're concerned for the talk, what you need to know is that the process begins initially with ischemia, and then you get a sudden neutrophilic infiltration of the endocardium. If there's no reperfusions, which is to say if that ischemia persists, then this eventually gives rise to lytic enzymes and metalloproteinases, which will degrade sort of the collagen within the infarcted area, and that leads to necrosis, thinning, and eventually, as tissue becomes thinner and thinner, according to Laplace's law, you get higher wall stress and you can suddenly develop rupture. If that doesn't occur, however, so if you have some thinning but not bad enough to cause a rupture, then eventually you do get the development of granulation tissue, which forms, and going down weeks to months, you can have the development of a non-contractile scar. So certainly as time progresses from hour 0 to week, several weeks later, the tissue itself goes from very friable and acutely injured and inflamed to this kind of protracted, granulated, and scarred tissue. The reason why, I talked a bit about aneurysms previously. So that's kind of in the late phase where you have a completed infarct and a large area of contracted scar. Well, that scar is it's non-mobile, like it doesn't contribute to LV function. And so that, that's kind of the motivation between interventions for surgical restoration, is to try and restore the ventricle to a more contractile state where it's, instead of having a large area of stagnant blood that doesn't really eject properly, certain door procedure might be able to restore adequate function. But again, I'm not going to go too deeply into that. So starting first with ventricular septal ruptures, one thing for any sort of disease process in the Royal College and things they love testing on is different classification systems. So, and I think with good reason, because if you're presented with a pathology, you need to understand it well, to the point that you can appreciate, well, what makes, two patients who are on the surface presenting with similar complaints quite different, and then how could that potentially impact their management, and of course their outcomes by extension. So, some ways that post-infarct VSDs have been categorized is by the quality of the rupture site itself. So a simple rupture, which you can think of as a direct through and through communication. So if for argument's sake, you're staring at the septum, this is something that you could stick your forceps through and go from the LV to the RV. What's like a complex, by comparison, a complex rupture would be more serpiginous. So what serpiginous means is that instead of a direct through and through communication, the blood kind of dissects its way through the layers of the tissue, and it's not necessarily a straight shot through, but it might take sort of a less direct course through the tissue. Often these is particularly serpiginous, can be identified readily with echocardiography, but when it comes to the OR and to actually identifying things, it can be quite difficult to identify the location of a serpiginous rupture, because you don't have the benefit of that large, very obvious hole that you would with a simple rupture. Anyway, so that will potentially complicate repair. And then the other way that we tend to describe post-infarct VSDs is by anatomical location. So distinguishing anterior from posterior VSDs. And the reason for that, anatomically, anterior VSDs are much easier to treat. They're typically located towards the apex of the heart. So as I'm sure you guys are all aware from cabbages, it's quite easy to flip the apex around. And as far as repairing these, it's easy to incise the ventricle and to visualize these defects, whereas a posterior defect, which is located more towards the base of the heart, is much difficult to expose and to operate on. Now, I don't want you guys to make the mistake of assuming that this classification system applies to congenital VSDs. That's a completely different set of lesions, different etiology. Those are still described anatomically, but also in relation to the great vessels and depending on the ventricular, the relative size of the ventricles and things like that. So just be aware that congenital VSDs are described completely differently from these. In terms of natural history, the sort of thing that makes post-infarct VSDs somewhat interesting is that mortality is very high in the acute period, but eventually levels off. And population-based studies have suggested that after about 3 weeks, we start to get this leveling off effect where if, let's say, you're unfortunate enough to have a ventricular septal rupture and you don't die within the first 3 weeks, well, you've sort of selected yourself off as a survivor. And, chances are you can survive quite a bit longer, even without surgical intervention. And certainly this was the pattern that early surgeons observed, and initially that's how they treated patients. So they would sort of admit them, and if they died, acutely, it was kind of felt that they were just too unwell to be salvaged. They would wait several weeks, and then if the patient, could make it several weeks, then they would take them to the OR. But there was certainly a little bit of selection bias, self-selection bias between the patients. Yeah, and so that's what this quote by Daggett is sort of alluding to. So I suppose when he was practicing in the 70s, he would admit patients for 6 weeks and not operate them until a month and a half later, which is obviously a little bit unrealistic in today's day and age. When we look at STS results, however, we do still see a very strong mortality signal in the acute phase. So you can see there patients operated in less than 6 hours from presentation have almost a 70% mortality. So we have still taken some cues from the earlier generations of surgeons, and we tend not to operate on these acutely, but we're definitely not waiting six weeks to operate on these people. Typically, the inflection point, or as you can see here, happens after about 7 days. And I would say in practice, most surgeons typically will take these patients to the OR at around that time point. So give them a few days to sort of stabilize and for the tissue to begin healing and to move from that acute inflammatory phase more into the granulation phase, which makes it easier to repair, but definitely, we're not waiting weeks and weeks and weeks to operate on these people. So medical management is generally centered along trying to minimize the impact of the shunting that patients can have. And so what that means is firstly reducing afterload. This can be done pharmacologically or sometimes mechanically through things like a balloon pump. Basically by reducing the afterload and reducing the EDP in the left ventricle, you'll subsequently get a reduction in left to right shunt. Of course, if you're shunting blood from your left side to your right, your cardiac output is going to suffer as a result. So you need to maintain that in order to maintain systemic perfusion. You could consider inotropes for this or mechanical support if required. Because so there's often patients will struggle with RV failure from sometimes the infarct itself, but also the acute volume overload that is now occurring as a result of the shunt. And so volume status optimization becomes very important there. As I alluded to, a balloon pump is often a cornerstone of mechanical support, and I'll talk a little bit about mechanical support towards the end of my talk. Just in terms of stabilizing people for that 7-ish day period before they might be ready to go to the operating room. But generally preparing for that high likelihood of RV failure, even in patients who initially present and might be diagnosed with a VSD and quite stable, they still have a propensity for the rupture site to enlarge, for the shunting to get worse, and for RV failure to also get worse as a result. This calculation here, a little bit of math on the screen that you guys might recognize, is talking about shunt fractions. So another low-hanging fruit for the Royal College exam. It's not necessarily the most applicable to a post-infarct VSD because you're not going to sit there with a calculator and a patient in cardiogenic shock with a VSD and sort of decide whether or not to operate on them based on their shunt fraction. But conceptually, it's related, certainly in the congenital world. Many of the decisions about timing of intervention have to do with minimizing the long-term impact of left to right shunting, which over years and years can lead to like pulmonary hypertension and Eisenmenger syndrome. So I thought I would include the shunt fraction calculation just to refresh your memory on it and to sort of talk a little bit about it. It basically compares the amount of blood flow through your pulmonary circulation relative to your systemic circulation. And so if you have a shunt fraction of 1, that means your circulation is balanced, i.e. there's no shunting occurring within the heart. If you have a shunt fraction of greater than 1, well, then you're having more circulation through your pulmonary side than through your systemic side. So again, over the long term, this can be deleterious. If you have, conversely, a shunt fraction of less than 1, then you might be shunting right to left, and you have actually more circulation through your systemic than through your pulmonary arteries. So again, just putting that out there is something to be aware of and to refresh yourself on if if any of what I'm saying doesn't immediately click with you. As far as surgical considerations, in my opinion, there's three sort of general principles when it comes to repair of ventricular septal ruptures. So first has to do with the quality of the tissue, and I alluded to this previously, but in the immediate infarct phase, the tissue is very friable, and passing sutures through freshly infarcted endocardium is a recipe for disaster. I heard one surgeon describe it once as trying to sew into like hamburger meat. So your sutures can tear very easily through the tissue, can make it very hard to secure an adequate size patch in place. And even if you do manage to place a patch, there's no guarantee that once the heart is loaded, that the patch will not dehiss. So the first principle, I think probably the most important principle, is making sure that when you perform a repair, that you're fixing your patch onto adequate
Hey guys, it seems like we might just be having some quick technical difficulties. Hopefully we'll be back in 10 seconds. Dr. Muller-Moran's just having some Wi-Fi issues, but he should be back on in a minute. He just texted me.
Hey, sorry about that, Asher. Is it working now? Yeah.
Yeah, you're all good.
Okay. At what point did I drop out there? Was it while I was talking about repair techniques?
You were still at surgical considerations.
Surgical considerations. Oh yeah. Okay. Give me 1 second to. Okay, we back online now?
Looks great.
All right. Sorry about that, guys. So had I made it all the way through this slide then, Asher?
I believe you were just talking about techniques.
Okay, yeah, perfect. So then this was my next slide. Okay, so then talking more about specific techniques. So these are all images taken from cone. I think I'll say in real life, they're not, the pictures look really nice. It's not like that in practice, but I think this is still helpful as far as understanding, approaches and general principles to repair. So one of the first repairs that's described in the textbook is this technique of apical amputation. I have to say, in my experience, this would be a very unicorn type of case. But let's say you do have a very apical VSD. As the image describes here, you could potentially repair this by just debriding away all of the infarcted tissue and suturing the remaining or buttressing the remaining layers of the heart back together. I think this illustrates the sort of 3 points that I was talking about earlier. So firstly, likelihood of a good repair, of not having residual VSD. Well, you can see with this repair, there is no VSD anymore, right? The apex has been all sutured together. There's no further communication between the left and right side of the heart. If you do have residual VSD, it's essentially going to be external. So you'll see that you'll start bleeding and stuff in the operating room. But so that would satisfy the first core principle of VSD repair. Secondly, as far as maintaining ventricular volume, well, again, you're debriding away a minimal amount of the ventricle, at least the way that the image describes it here. So you're not likely to get into the situation described earlier of having too low of a stroke volume. And then finally, you're geographically quite removed from the mitral valve and the papillary muscles, so you should be able to do this type of repair without, with a low risk of mitral valve interaction. Infarctectomies, this is one of the more, when we talk about repairs, the two kind of most described ones are either infarctectomy or infarct exclusion. This one, I'll talk a little bit, right now, I guess, about how this potentially is less optimal. So what this involves basically is debriding away all of the infarcted tissue, and what the image is showing is basically suturing the site of the VSD directly to the epicardium, so a direct suture closure. This could be problematic for a few reasons. Like I mentioned already, the tissue is not necessarily going to be nice and strong the way the image is suggesting it here. So, I think this would place a lot of tension on the rim of the VSD. I think this would have a high possibility of leaking. You are going to shrink the LV a little bit, but not as much as with other approaches. So it's sort of, I suppose you could consider it half of one or half a dozen of the other. And what's the expression? 6 of one, half a dozen of the other. So at least the way the image describes it, it sort of has some pros and cons. But I think what would be a better repair is what this demonstrates here, is to use a patch. So by using a patch, you're not going to have as much tension on the site of the VSD. You'd have less likelihood of a residual leak. You are going to still have a nicely sized ventricle, although keep in mind the size of the patch will impact your LV function. So the patch is obviously non-contractile. So if you have a very large patch in there, you're going to have a very large portion of the septum that isn't really contributing to cardiac output. Now, I've sort of alluded to posterior defects being particularly hard to close, and that's what this diagram shows. If you have, now you're operating at the base of the heart, so you can imagine exposing this would be quite difficult, quite challenging. There's going to be a high tension area here because there's more and more shear forces at the base of the heart. And certainly as you get closer and closer to mitral annulus, the likelihood of cords or papillary muscles becoming involved and potentially becoming dysfunctional as a result of repair gets higher. So this is not just technically difficult lesion to repair with this type of approach, but also high likelihood of either failure of repair or of inducing MR or other sort of problems that you'll have to deal with in the operating room. Infarct exclusion, apart from infarctectomy, is the second most, or the other commonly used technique. This was popularized by Dr. David in Toronto, and it's quite clever. So it sort of mitigates some of the problems I've been alluding to with poor tissue quality and with tension by suturing a patch onto healthy tissue that is remote from the infarct site itself. So in cross section, this is what we're talking about. On the one side, the pericardial patch is fixed to the base of the ventricular septum, and on the far side, it's fixed to healthy myocardium. So you're not likely to have much of a leak here, and you've done a good job of excluding the rupture site from the direct pressure of the left ventricle. Now, the potential downside here, as you can probably appreciate, is that with this large patch, you're essentially reducing the size of the left ventricular volume. So that is one thing that you should be aware of. And another principle I meant to mention earlier, all of these patches you'll see are affixed on the left side of the heart. If you have any experience in congenital, you'll know mostly they fix congenital VSDs from the right side. But one of the principles here is that because the patch is on the left, when the LV fills and when it contracts, that pressure on the patch is basically pushing it into the septum, and the septum is sort of serving as a backstop, or the myocardium in this case is serving as a backstop. Whereas if you had placed the patch on the opposite side or on the far side of the ventricular septum, and every time the heart contracts, it's going to be actually pulling the patch away from the septal tissue. So again, that's going to be a factor that's going to have a higher likelihood of producing a leak or a dehiscence of the patch. Just for completion's sake, talking about infarct exclusion repair of a posterior defect. And, I've sort of said this many times, I feel like I'm repeating myself, but these are technically challenging, and you can even see here how close the papillary muscle is. Yeah, but this is how you would repair it with the infarct exclusion method. So post-op in the ICU, what are certain considerations? Well, I've alluded to balloon pumps. These can often be used pre-op to help bridge patients, but they're also quite helpful post-operatively because the balloon can help, like anything that reduces your EDP is going to give the septal tissue more time to heal, and it's going to reduce the likelihood of a patch dehiscence. So, one of our most experienced surgeon, who probably has the most experience in VSDs at our center, he advocates for routine placement of balloon pump for 1 to 2 days after surgery, regardless of the patient's hemodynamics, for that exact purpose of offloading the LV as much as possible and giving the septum and the patch as much time to heal as it might need. You have to be aware, like I've said already, this is a bit of a dynamic situation. So a repair that looks great in the operating room might look not so great a few days later. So if you're caring for these patients and they start to deteriorate and you're sort of scratching your head wondering why, you have to keep in mind that it's a possibility that a leak which wasn't present in the operating room has now developed as the patient has, been resuscitated in the ICU and perhaps as the infarct has completed. If you were very academic, you could use the QPQS calculation to sort of prove your theories and to monitor a patient's progression in the ICU. But certainly echo would be diagnostic in this situation. And if needed, this isn't always something that requires another operation to fix. These could potentially be treated in the cath lab. So you'll have to obviously make connections with your interventional cardiologist. But if it's a small, residual shunt, this is something that is potentially closable with a transcatheter device. Again, for ICU care, RV failure is something you have to be very aware of, especially with posterior infarcts. So posterior infarcts, the RV is going to be involved, and it's still struggling from the volume overload that it suffered while the septum was shunting. So you may have to nurse the RV. I would say management of RV failure is very high yield for the Royal College. So I have a slide to go into that into greater detail, but essentially the way I think about it is sort of pre-pump or pre-RV, preload type of situations. What are actual RV parameters I can optimize, and then post-RV or afterload parameters to optimize. But I'll get into that a bit later. You should be aware that percutaneous options for closure exist as a primary treatment modality, but these are by no means standard of care. So the reason for that, and the reason why I've included this diagram, is that any percutaneous repair is going to be contingent on finding a properly sized device. And you can see from all the arrows here, these devices have a certain size waist, they have a certain size rim. There is, of course, the size of the device itself as it's delivered over a wire. And so to actually fix a VSD, you probably need a simple defect. So again, that's going to be a through and through defect that's easily crossed with a wire, and one that's located in a region of the septum where you can deploy a fairly large size device such as this with an outer rim that's not going to interact with the mitral valve or with the base of the heart, potentially eroding through it. Certainly, serpiginous defects would be difficult to access and to repair percutaneously, but just because you can't cross it with a wire quite so easily. So again, you should be aware of these, but I think surgery is still the treatment of choice for these people. Interestingly, if you look at data that have been done on series of patients undergoing percutaneous repair, they largely mimic what we already know from the surgical population. So if you see on the bottom, they've sort of talked about acute phase patients, so patients presenting or treated within 2 weeks of their infarct. And as we move to the right, and in studies that have included more and more patients in that acute phase, the mortality is higher, just as we saw with surgery, mortality of 70% in the first 6 days. Well, then in the transcatheter world, these patients also tend not to do that well if they're intervened on immediately. But as studies have enrolled, or studies who have enrolled patients who are more in the subacute phase, they've had better results as a result. So it's the similar concept as far as ideally waiting for a predefined period of time before taking these people to either the operating room or to the cath lab for intervention. Any questions on VSDs before I move on to free wall rupture? All right, hearing none, I'll just move forward. So free wall ruptures, so similar pathogenesis to VSD. It's just the difference between involvement of the ventricular free wall as opposed to the ventricular septum itself. And once again, just getting in the habit of characterizing these, of classifying these. So I've sort of included some descriptions here of classification systems that have been used. People talk about a blowout type of VSD, which would be analogous to the simple VSD, or in other words, a direct through and through type of defect. And you can see in the top left image, that's showing blood just squirting directly out of the heart itself, versus an oozing type, which is more of a serpiginous defect, more complex. And, instead of a frank rupture out of the heart, we have more of this pattern of blood sort of dissecting through the layers. There's also this concept of a sealed type, which really could be either initially blowing out or oozing type, but that has sealed itself off basically through the effect of the ensuing pericardial tamponade and then the coagulation factors that have now basically closed off the hole. But it's a hole nonetheless and could still be tenuous. Woo. So medical management, these patients are generally very sick. Medical management is basically get them to the OR as soon as you can. They have a high likelihood of mortality, whereas the VSD patients have some temporization in that you're just really managing the shunt and you want to ideally wait a few days. These patients have an acute infarct and they're generally in tamponade. So do what you can to support their blood pressure in the meantime. Inotropes and vasopressors are your friends. Give them volume. As we know, tamponade is a preload dependent state. You could consider pericardial drainage, although I put this as plus minus because I would not recommend that as a routine approach. The reason for that is once you insert a drain and you now have a pressure gradient from, let's say, your left ventricle to your pericardium to the drain, you could actually convert a previously healed or the one, what do they call it here, a sealed type of free wall rupture into a free rupture now, because now there's pressure relief allowing for the heart to continue bleeding into the pericardial space. So I think this is a situation where you are likely better off with a patient who is medically unstable, but in a stable fashion or on stable doses of inotropes and vasopressors, even if they are high doses, rather than putting a drain in and potentially converting this patient to now like an acute, transfusion emergency. So because of tamponade physiology, these patients can become very unstable with induction of anesthesia. I can sort of go on a bit of a story time here. So in the case that I was involved in, I had asked the team to prep the patient awake, and I got peripheral access prior to induction of anesthesia because I was worried about them becoming unwell. And you have to be prepared for these drastic blood pressure swings because, again, as you relieve a tamponade, I'm sure most of you have seen this, the blood pressure skyrockets because the patients are on rocket fuel. You relieve the tamponade or the source of their obstructive shock, and then suddenly all the blood pressure meds kick in. And so that's quite deleterious if you're talking about a potentially sealed over free wall rupture, because again, high pressure within the heart is going to have more of a propensity to leak at the rupture site. So in my particular case, I had asked the anesthetist to be prepared to reduce the drugs once we opened the pericardium, and he basically misunderstood me and he turned off the drugs before we did the sternotomy. And so the patient almost died as we were opening up the chest. And thankfully, though, I did have peripheral access, so I was able to put them on pump quite quickly and then open up their pericardium and do their procedure. But it just goes to illustrate that you need to be very clear with communication, and that these patients can be very unwell. I'll talk a little bit about repairs on the next slide. Generally, these aren't quite as varied as with the VSDs. There's less to consider as far as the considerations I talked about with ventricular volume or with the risk of a recurrent VSD or mitral valve interaction. I mean, at the end of the day, you need to somehow seal off the endocardium that's bleeding. You don't always need to do this with bypass, though. It's sort of dependent on the nature of the rupture and certainly the location, how much exposure you can get just by manipulating the heart, or if there's a lot of hemodynamic instability, you might need to go on just to facilitate exposure and repair of the site. I would say the two general ways of repairing these are either with or without sutures. Certainly the top line here, you can see these are all methods that would involve a fair amount of suturing. And my advice would be if you're suturing on these hearts, you want to do that on pump and ideally with the heart arrested, because every time the heart beats and the concepts I talked about with regards to friability of the tissue in an acute VSD definitely apply to the myocardium. So if you're suturing on a heart that's beating, chances are your sutures are going to tear and tear and tear, and you might actually make the problem worse. So I would recommend doing these on pump, the heart arrested. Take nice, big, deep sutures. Use felt to support your your bites, and do as much as you can to be confident that there's not going to be a leak once the heart is loaded. Certainly the blowout type VSDs probably are going to be more dependent on this type of repair with cardiopulmonary bypass. As we go to the bottom row, these are sort of moving into less and less suturing. You could consider potentially doing these without pump, certainly the bottom right. And this is the repair technique that we tend to use most commonly at our center, especially if it's an oozing type of VSD, is just to place a lot of bioglue on the heart and patch and hold it in place. And oftentimes, because it's not a discrete rupture site, it's more of that serpiginous type of defect that I talked about previously that's eroding through the heart. Oftentimes, this actually does quite a good job of sealing off the defect without needing to go on pump. I would say in my anecdotal experience, the major contributor to instability in these patients is the fact that they're in tamponade when you first see them and bring them to the operating room. And so once you've relieved that, they generally do okay, or at least out of the 3 types of mechanical complications we're talking about today, they probably have the most stable type of course. But you're still managing the residual effects of the infarct and whatever period of ischemia they had until they went for definitive repair. Percutaneous options. I would say for free wall ruptures, percutaneous options really should just be limited to management of the tamponade. And what I mean by that is if the patient is literally coding, you can't make them much worse. So perhaps you could consider a drain in there to relieve some of the tamponade and get a little bit of blood pressure room. But if they're stable on high doses of inotropes, I would just leave them and concentrate my efforts on getting them to the operating room. There have been some talks or some descriptions of transcatheter techniques, which have done things like using closure devices where you access the rupture site with a wire and then place a plug across it, or even accessing the pericardium with a needle and injecting fibrin into the pericardial space to hopefully seal off the rupture site. I think these are highly experimental. They're by no means standard of care, and my recommendation would be don't do these in your patients. Moving on now to papillary muscle rupture. So I've sort of alluded to this, but just to reemphasize, there's a spectrum when we talk about acute ischemic MR, which could be anything from papillary muscle dysfunction to LV dysfunction to finally frank rupture. And that's what the image is showing here. Generally speaking, this is the posterior medial papillary muscle that is involved. And the reason for that is that it has a single blood supply, usually from the posterior descending artery. So the anterior lateral gets blood from the circumflex and from the LAD, which, if you think of the mechanisms of mechanical complications, which is an acute arterial occlusion, well, even if you occlude, let's say, one of your circumflex branches, your pap muscle is still likely getting blood from the septum and from the LAD, so less likely to infarct, whereas the posterior medial is going to be more dependent on that singular blood supply. And the reason why this is particularly important is because these patients generally will also have a concomitant RV infarct. And so this is the triple hit that I alluded to, where they have severe acute MR from the papillary muscle rupture, their cardiac output is compromised, they're in flash pulmonary edema, so their respiration is compromised, and then finally they're dealing with RV failure, potentially causing high venous pressure and poor perfusion of their vascular beds. So again, you want to make sure that you tailor your medical management with this in mind, optimize their volume status. If it's not uncommon that these patients may need mechanical ventilation to help manage their oxygenation. Although if you're able to avoid it, it's probably a bit better for the RV in all honesty. Reduce afterload as able to offload the RV and to encourage the ventricle to eject antegrade as opposed to retrograde through the mitral valve. Finally, you want to avoid medications like beta blockers that are going to cause bradycardia. Not only is that going to reduce your cardiac output, but it's also going to prolong your regurgitant time, which is obviously not a good idea here. As far as surgical considerations, I would say the overwhelming majority of surgeons are replacing valves when they're confronted with an acute pap muscle rupture. That's not to say that people haven't attempted or even described repairs. It certainly can be done. I think it's high risk for failure, though. And this isn't a patient who is an elective MR who could potentially tolerate multiple pump runs for you to get the repair just right. These patients are still very sick. You may only have one shot to get it right. And so, yeah, generally speaking, contrary to most mitral surgery, the dogma is more of replacing rather than trying to repair the valve. I think the other thing that bears mention, because it's a bit of a departure from routine mitral surgery, is that chordal sparing may not always be possible or even advisable. And the reason for this is because what are you sparing here? Like, the papillary muscle is ruptured, the cords are flailing. There's by definition, you're not really sparing much. And particularly if you're implanting a mechanical prosthesis, you could have any of that necrotic material potentially entraining into your valve leaflets and preventing them from opening or closing properly. You could have dehiscence of your sutures if you're trying to do a chordal sparing technique and you're including necrotic material in your suture line. I think ultimately your goal here is to get the patient out of the operating room safely. And although we know chordal sparing is desirable for long-term outcomes and for long-term ventricular function, I think this is really a situation where you need to get in and out. And I think it's totally appropriate to avoid the chordal sparing technique in the interest of just getting a repair that's fixed properly and durable, and that's not going to cause the patients any problems in the operating room. So I wanted to save the talk of RV failure to this point because, again, this is high yield and it's probably most germane to the acute MR patients. That being said, RV failure is a very high yield topic for the Royal College. So again, my approach that I usually think of this is as sort of pre-pump, pump, or post-pump. And in this case, when I say pump, I'm talking about the RV. So pre-pump is optimizing all of your filling conditions. So what is your volume status like? What is your CVP? What is your rhythm like? So ventricular pacing in general is going to be worse for the RV than sequential pacing or than even just native sinus rhythm, because the ventricle doesn't contract normally when it's being paced on its epicardial surface, as opposed to if you're using the His-Purkinje system. So whenever possible, RV failure patients, I like to have atrial and ventricular wires, ideally in their own rhythm, or at the very least pacing them atrially so that they're conducting through their ventricle using their native conduction system. As far as pump parameters that you can optimize, this generally is going to be in the form of inotropes. You could also consider mechanical support. I'm sure Pierre talked about right-sided mechanical support, and I do think this has a role as well in the management of RV failure. And then finally, post-pump parameters. This is everything past the RV, so mainly RV afterload. We're talking about pulmonary vasodilators here. You can consider inodilators as well, like milrinone. I think your ventilatory management is also optimal. So things like high tidal volumes, high PEEP are going to indirectly increase the RV afterload and potentially make it more difficult for the heart to empty, such as well as the case with hypoxia and hypercarbia. Those can induce pulmonary vasoconstriction. So know this, memorize it, love it, and learn to regurgitate it when asked. As far as percutaneous options for papillary muscle ruptures, so this is actually quite an active area. We know that MitraClip is gaining more and more of a role in the treatment of patients, and I can't say that I have any experience specifically with MitraClip in the setting of a papillary muscle rupture, but there definitely have been reports. These are still mainly single center or small case series, but it's an interesting thought experiment. I think, in my personal opinion, that there's still going to be significant hurdles that need to be overcome in these types of patients. So, from my experience with the MitraClip, it's a very precise procedure that requires, coordination between anesthesia, interventional cardiology, and echocardiography, which I think is going to be very difficult if you have a patient in acute pulmonary edema who's hemodynamically unstable. I think it's just going to be very difficult to do the procedure in an efficient and safe manner in that type of setting. But again, this is just me speculating. I think as well, I would imagine that because you have to do a MitraClip through transeptal puncture, that's probably not the best option if you're from an RV failure perspective to introduce another source of left to right shunting. Anyways, it's been described by and large, surgery is still the gold standard. I think maybe at certain high volume centers, if a patient has been denied surgery and their only option is palliation, well, then maybe that would be a situation where you might consider a MitraClip. But I think for most people, it's still not commonplace. So getting towards the end here, I wanted to just talk a little bit about the role for mechanical circulatory support. When I was in my residency, I had a bit of an area of interest, you could say, in MCS and mechanical complications. I was fortunate to publish a little bit on that, so I thought I would just share a little bit of my kind of insights, such as they are. And you might have realized that talk of MCS was notably absent when I was speaking about surgical and ICU considerations. So I think the three modalities that might potentially be or that are of use in these patients are firstly balloon pump, secondary ECMO, and I'm talking about VA ECMO here, and finally axillary MCS devices like Impella. I think balloon pump is probably the go-to for most of these because it's easy to use, it's easy to institute, it accomplishes a lot of our goals as far as offloading the heart and potentially bridging to either the OR or even to a more extensive form of or more supportive form of MCS. Certainly ECMO is going to be a step up in that regard. It still provides the LV offloading benefits of a balloon pump, but to a greater degree. It supports the hemodynamics, but to a greater degree. It could potentially take someone who is acutely unwell with metabolic derangements and allow them to recover in the ICU with correction of, lactate and end organ malperfusion and things like that before potentially taking them to the operating room. Certainly, I can think of patients who were deemed non-operative candidates because of, very profound shock, who got put on ECMO and then within a couple of days actually recovered to the point where they were subsequently well enough to go to the operating room and actually had a good outcome at the end of the day. And then finally, axial MCS. Pierre-Emmanuel talked a little bit about this. It's controversial because, I would say that a lot of the conditions here are probably, some would consider contraindications to the use of an Impella. We talked about the possibility of converting a left to right shunt from a VSD to a right to left shunt with the placement of an axial flow device. We talked about the embolization of necrotic material from the heart, which might still be in an incomplete phase of infarction with the placement of Impella. There's also a time factor to be considered, so ECMO can be started quite quickly, whereas Impella requires more equipment and wire exchanges and things like that. You're probably not going to get an Impella in as quickly as you could put someone on ECMO. That being said, obviously Pierre has some colleagues who have done it successfully, and I can't say we've done this at our center, but maybe it's something we would consider in the right patient. I think at the end of the day, you need to keep in mind why are you putting this patient on MCS? What is your ultimate goal? And I think that can help you strategize as far as what modality of MCS is most appropriate. Just as a refresher for the VSD, you're ideally hoping to bridge them for several days before taking them to the operating room. ideally, I think if a balloon pump should be, you know, in an ideal situation, that's all you would need, because the patients are generally a little bit more stable, and you don't need to put them on the whole, you know, song and dance of VA ECMO for that long before taking the operating room, although certainly the situation might dictate that. For free wall rupture, your goal is to get them to the OR as soon as possible. And I would say this includes without MCS, if MCS is going to delay you. I think ECMO probably has a greater role here, just from the standpoint of stabilizing an acute tamponade patient, although understanding that that's not going to do anything for the underlying tamponade. Like, they're still going to have free wall rupture. They're still going to be, you know, obstructed centrally. But ECMO, you know, could buy you the time you need to take the patient from the ICU or the floor, wherever they may be, and get them to the operating room. And then finally, for papillary muscle rupture, really what you're trying to do here is not just support their hemodynamics, but also to help manage their pulmonary edema. So this, perhaps in my mind, would be the most ideal use case of an Impella, because if you can just reduce the amount of regurgitant blood in the LA, then you should be able to mitigate most of your problems. But again, that's a little bit speculative on my part, so I don't want to say too much. Okay, finally, I want to talk about the role for revascularization. I think as residents, and certainly with the view to the Royal College, need to understand what the guidelines say, and when you're sort of answering these questions, you need to be prepared to quote unquote practice by the guidelines. And the guidelines say that patients who have had mechanical complications should undergo CABG at the time of surgery. Now, is this actually done in practice? I would say it's very controversial, because firstly, there's sort of logistical and time considerations. So a patient's in the OR, you know, do you really want to spend time? I mean, let's say it's a free wall rupture and you haven't required the use of pump. I mean, do you want to put them on pump just to bypass an artery in an area of the heart that is more than likely completely infarcted anyways, right? Versus just getting them to the operating room and back up to the ICU. I think the same rationale holds true for pap muscle rupture or for VSD. That area of the heart is clearly very infarcted for the patient to be in the situation to begin with. So there's probably, there may be minimal benefit to adding a CABG. I know the guidelines state it's class 1 and that it improves survival, but you have to understand there hasn't been any randomized trial where patients have come in, you know, okay, this is VSD, we're going to randomize them to a CABG or not. Like, that just hasn't occurred. So these are all retrospective studies, and again, you should know the guidelines, but you should also know the sort of rationale around why you probably don't see that as often in practice. Certainly at our center, I would say our general approach is not to bypass the arteries. We do the repair that needs to get done. We get the patient out of the operating room. If needed down the line, you could consider a PCI if it's really needed, but we generally don't focus on bypassing the culprit vessels at our center. And that's it for my talk. So I hope timing is okay for everybody. Yeah, I'll happily take some questions.
Yeah, so thank you so much, Dr. Moran. That was fantastic. If anybody has any questions, feel free to put your hand up. Or if you want to type in the chat, you're more than welcome to. Yeah, Kenza.
Thank you so much, Ricky, for the really good talk and all your tips on how to study or what to focus on for the exam. I have 2 questions regarding your last point for concomitant revascularization. So you said that at your center you don't revascularize the infarct-related artery, but how about concomitant significant disease? That's my first question. Would you address that?
Yeah, again, so generally speaking, these aren't generally going to have a lot of residual disease, because chances are they haven't had the collateral networks, and it's generally going to be a single culprit artery that's become infarcted. Yeah, I suppose if let's say there is a situation of more than one territory, I think there could be some benefit in that case to revascularizing the rest of the heart. I think I'd have to think about it case by case though, and which artery do I think is most responsible for the lesion versus what do I think the relative benefit is of, adding on bypasses to other territories. But I'd maybe consider in that case though.
Thank you. And my other question, maybe I'm overthinking this, but in the 2025 ACS guidelines, there's a section on mechanical complications, and they don't even mention revascularization at all. They only talk about the fact that patients should be revascularized or treated in a center with cardiac surgical expertise, and they talk about MCS. So should we then read between the lines that revascularization is probably not really relevant, or does the 2021 recommendation still apply? And I guess this question could apply for any other field of cardiac surgery with updated guidelines. So what are your thoughts on that?
Yeah, that's a good question, Kenza. So I think in general, the newest guidelines are the ones that you should know the most about, that you should focus the most on. I think previous guidelines are still helpful in addressing the holes that maybe have been left out of the most recent guidelines. So the example I always use in this regard is when you look at the valvular heart disease guidelines and the newest iteration, which really only talked about left-sided endocarditis, versus in 2015, there was a whole section on right-sided endocarditis. So so in both cases, you need to know the most recent guidelines and, use those to guide you the most. But let's say, you got a question on right-sided endocarditis and that the newest guidelines haven't really talked about that. I think it's very legitimate, and I don't think you can be penalized for saying, well, this was not in the newest guideline, but in the previous iteration they talked about this, and so that's what I would do. I think probably the fact that it's not in the newest guidelines, and you're right, they only talk about using MCS, it probably speaks to the fact that it's controversial, right? So whoever's on the writing committee at the time may have felt that the previous statement, which was a class 1, that's pretty strong, right, was probably a little bit too forward for recommending that in all patients, and that's probably why they left it out of the most recent guidelines. Yeah, does that answer your question, or?
Yes, I think so. Yes, thank you.
Any other questions before we go, guys? Alrighty. Well, then I think that concludes our session for today. Thank you so much, Dr. Moran, for your time. I know we all really appreciate it. Just so everyone knows, I think we'll take a break for the summer, and we won't have another National Academic Half Day until probably September, October time. But Yuan, Teresa, and I will chat about it, and we'll be in touch over email in the coming months. So thank you all so much for coming, and thank you again, Dr. Moran. Have a great weekend, everyone.
Yeah, thanks, Asher. And anybody, if you want to reach out to me directly, those of you who have my contact information, don't be shy. Those of you who need it, feel free to ask Asher. But yeah, enjoy your weekends and enjoy your summers.
Perfect. Have a good one, guys.